So, few things which Hemant's talked about it, I will also speak about it. That I started my joint replacement career in 91. There used to be one joint available, How Medica. Three sizes were there, small, medium, and large. And it's like 30, 60, and in between there was a 45. Okay. So these joints only available, total condylar joints. Then came the PFC and IB2 and other joints. One of the concept of alignment was established with full alignment X-rays, and wherever there was a malalignment and failure, the revisions came. We learned through all the system of manual instrumentation, and this was one of the oldest PFC system which we have learned and gone through and done the things. Now, this is my one of the own knee, 20 years follow-up with all poly. So, do you need anything else? As the Hemant was talking about it, least done, least talked about it, and this is 20 years. Patient stays near Bombay, somewhere in Vasai actually, and I've done it 20 years back. Another of my 18 years follow-up of a conventional way of doing it, RPF, though it was not had success in many of the hands, but we had a great success. And from there I changed from fixed bearing to the mobile bearing or rotating platform concept. And how I've come back to the... So after that, the things started coming up, the computer navigation, which we have learned in 2006. And we've learned all the points which we were talking about, alignment and balancing through the navigation system. And today what Velis system is there, it's a glorified navigation system, which we are doing it. So we have modified our mistakes of a manual instrumentation, which we're doing it through a computer navigation system, and could give a better alignment or better cuts to the tibia, to the femur, the rotation, which we have learned in academic workshop, doing on the patients, also that teaching and learning all the time. And that's how this was the only system which could tell you the correct femoral rotation, and we had no problem whatsoever with the navigation that time. And this balancing with the tensioner, which is also there in the Velis system, was also there since 2006, and we have learned and gone through all those things, and we started doing bilateral knees with all kind of designs available to give an excellent function. Obese patient, definitely the navigation helped us a lot, and we could manage it. And through that, I graduated slowly towards the CR knees, and I do all my knees now, the CR knees, because the Indian patient with a small size bone, and I do all CR rotating platform attune, and using all kind of technology and the techniques. So this is one of the CR 150 knee, which was one of the my favorite knee. I used to do it. It's not available in the sizes. Years together I've done it, and I've got more than 15 years or 14 years follow-up for these patients as well. So one of the paper was published in Australia after this computer navigation system was there, that if you do as many as computer navigation system, you become a better surgeon. You can do a manual or the mechanical, what you are doing it in a better format if you do a computer navigation system. So this is the knee, which I've done many of them. In fact, this is the knee I've done with complete eyeballing, no system use, only using the saw. One shot tibial cut, one shot femoral cut, one shot rotation, all. And this is without any instrumentation, without any navigation. I've done many of them, more than hundreds of them. But this has made my journey in learning with the computer navigation, how precise you could be, how can you feel the knee, how could you feel the ligament tensioning, and you can do even the knees without using any instrumentation if you are really experienced and you don't need any technology there. But this was the demand of the day, and came the Velis. So we started doing the Velis system. All the things have been talked about, so I'm not going to speak about the Velis system. But yes, it's the system which gives you a titration of your bone cuts. It's a system which gives you the titration of soft tissue, you have to have that feel with an experience first, doing a conservative surgeries. Your hand should feel what's the soft tissue looks like. Every knee is different, every incision is different, every quadriceps is different. If you have that feel and then use the technology, you can titrate the things and you can play with both those numbers like a child. Okay, it's a cubic which puzzle which you have to play with it, and you have to fit and fit and press the button. That's it. But provided you know your job of handling the soft tissue better, provided you know how the patient is going to perform the knee bending, how the things are going to be. So this is the system which is very simple as compared to the, before I went into this, getting this system, I used all my system. I pressurized all the companies to get me the robotic in my OR. I will not do one cadaver, I will not do one bony saw, or I will not visit any surgeon because I've been doing it navigation since 2006. And I've done all the navigation system, you name it, available, or robotic system with my patients. And I've found this is one of the most simplest way of doing all what they're talking about, getting it done in a brilliant way. So this is I do a femur first. Basically, I'm a CR. I do all my CR RP attune, rotating platform RP attune. So this has been talked about. I'm not going to talk about it. The few things, yes, if you have a real-time tissue handling, real-time gap balancing, which you can do it. You can customize the planning during the surgery, and of course, you have a less radiation, and it can be individual patient-specific alignment you can do with this system. The screen is very versatile, but please believe me, once you start doing it, don't be in a hurry. This is the place where you have to give a lot of time. This is the place when this screen comes, you have to think 10 times what you're doing it, what your knee is going to be like, and you give a lot of time on this screen and manipulate the numbers. Just don't see that number here. You have to sometimes see if this patient is going to need some release, this number will change. Okay, and you will be in this problem. So you have to be very careful about learning this screen and doing this screen if you're doing it. What are the key advantage? Everything has been talked about by two or three of them, so I'm not going to speak about it. Few example of doing it. One of the varus knee is again a rotating platform RP knee, and believe me or not, I have never used more than 5 millimeter of inserts in attune RP knee so far. So if you have a correct bone cuts, correct balancing, you will not need even the bigger inserts as well at all. This is another of my knee. If you see, it's perfectly well aligned. Okay, and you have a very small incision, and they look like, you know. So I spoke to one of the guy who came from US, who was from J&J, very good friend of mine, Vishnu Kalra, and I showed him the X-rays. So I told him, looks very sexy. He says, orthopedic surgeon only tell the knee is very sexy. Otherwise, nobody can say the knee is very sexy, right? So it looks all sexy. Patient-specific techniques, you can, you have so much to learn with this system. But provided your basics are correct, you know the basics, don't jump into the direct robotics. Do a lot of training, and be a part of Indian Orthoplasty Association. So we're doing a lot of training. We have recently done academic course. You all are invited to join IIA, and of course learn all the basics first, and then jump back to the robotics as well. A knee with the valgus, okay, and we are again doing a study, and if you see the knee is so perfectly well aligned with using this navigation system, and patient has a functional good result. The basic fundamental advantage of using this technology, which we have found having so much of experience for more than 30 years, that patients when you titrate the soft tissue, you have a correct balancing, correct positioning of ligament, the patient recovery is faster, what the people are talking about, because you are managing the micro instability of the patients on the table in a dynamic situation. Okay, though you are not doing a dynamic thing on the table, you're doing static thing, but you can feel that dynamic thing, and patients' knees are very stable. That's one thing which happens. Second thing, they get really, most of the patients, I'm sure everybody's patient, Hemant or Rajkumar, they get a very good early bending. They get straightway 90-degree bending, and they're very comfortable, they're very confident. See, the thing is, the recovery and everything, it's a mind game. The patient, the moment the patient has less pain, patient stands, patient flex the knee, he starts walking. So there's nothing to do with the technology here. It's a mind game. How well the patient is satisfied and get the results immediately, they start doing the things. And here the technology helps to set the mind of the patient for a proper recovery. That's what I can say. And that's how I can connect my journey to robotics from only 3 joints available that time in 91. Thank you so much.